This week we're going to look at U.S. healthcare payment systems, both from a historical perspective and also what's going on currently and where this might lead.
Reimbursement for healthcare services in the United States fall roughly into two large categories, retrospective payment and prospective payment. So this slide is just an overview of those two approaches. For several decades, up until the 80s, retrospective payment, where it was a charge-based system, was the predominant system for healthcare services. Hospitals or clinics would put together an itemized bill, and on the hospital side, as a manager, I could simply add whatever costs I felt were appropriate, such as um, any sort of supplies, uh, the cost for a more intensive sort of care, the ICU versus intermediate care, and put that on the bill, and the insurance company would pay for it. And it was really quite remarkable. In the 80s, I was at the University of California, San Diego, and I wanted to give out a whole pack for women to take home after giving birth, and I simply added it to the bill. It was pretty great. The bad part was it was not really based on what it was costing us to provide services, but more on what we decided to charge, sort of like a hotel. Cost-based reimbursement is not based so much on actual costs, what it costs me to provide the care as a provider, but a cost-based reimbursement system that is what is allowable. That's sort of negotiated with the third party payer. And then there's also another approach to this called percentage of charges, which sounds a little bit crazy, but up until into the 90s, there were still insurance companies who would pay a percentage of whatever was charged on the bill. So I recall very clearly in about 1996 when we were putting together an annual budget, and I was at a budget meeting with our chief financial officer at the Sisters of Providence, and he was going to raise charges, which really surprised me. And I said, well, why would you raise charges when, for the most part, we're getting by that time, more of a prospective negotiated payment. So we knew what we were going to get, and we needed to manage within that amount. And he said, actually, we have a pretty good percentage, about 10% of our payers will pay on a percentage basis. So if we raise our charges, the amount we're charging for services, it actually will raise a portion of our income. And it was a significant portion. So that has pretty much gone away. Most of these are in the past, but they were present for many decades. Prospective payment is what we see for the most part now. And those payments are negotiated prior to the provision of service. For the most part, we see them negotiated by diagnostic group. So diagnostic related groups we'll talk about in another couple of slides in more detail, but I'm sure most of you know that's reimbursement based on the procedure or the diagnosis that the patient is admitted with. So a hip replacement or pneumonia or a vaginal delivery. And sometimes that's adjusted with a severity index, or how sick the patient is. I think most of you all know now that Medicare, though, has added something that strikes fear in the heart of most hospital chief financial officers, and that is that if there's a hospital-acquired condition, an infection is the usual, or a patient fall that causes complications, something like that, those are no longer reimbursed as of 2008. In addition, Medicare is also now penalizing readmissions for these three large categories, and I'm sure more will be added as time goes on: myocardial infarction, heart failure, and pneumonia. So if you are readmitted, your first time in the hospital was under one of those diagnoses, and then you're readmitted as a patient, the hospital must incur those costs and cannot bill for them. So it's a little scary to be the chief financial officer for a large hospital system now.
So we can't really talk about prospective payment without talking about diagnostic-related groups. In 1983, Social Security amendments where Medicare payments to hospitals were based on established prices rather than costs went into effect and was based on a diagnostic-related group system. That system was originally developed in the late 60s, believe it or not, at Yale University. And the original motivation for developing DRGs was to create an effective framework for monitoring the quality of care and the utilization of services in a hospital setting. So it's trying to standardize things across hospitals. And the first large-scale application of DRGs was in the late 70s in the state of New Jersey. So the New Jersey State Department of Health used DRGs as a basis of prospective payment, and hospitals were reimbursed based on a fixed DRG amount for each patient treated. So for hip replacement and so forth, this is what you're going to get for the bundled payment for the hospital stay and the whole schmear. Whereas before, of course, under fee-for-service, we would bill for drugs, radiology, use of the operating room, and when we had a very detailed bill that would go out with all of those things, and the pharmacy, radiology, all of those departments were actually revenue centers that could make money separately. And so for the first time, that was a bundled payment that was determined ahead of time. And boy, I tell you, we thought it was going to be the end of healthcare as we knew it. And I guess in some ways it was. So in 1982, the Tax Equity and Fiscal Responsibility Act modified the section for Medicare hospital reimbursement limits to include a case mix adjustment based on DRG. So it took that model and modified it a little bit, and in 1983 Congress amended the Social Security Act to include a national DRG-based hospital prospective payment system for all Medicare patients. And of course, other payers then followed this sort of model. Managed care came about in the 80s as well, and really tries to manage the utilization of benefits. So the type of care and procedures and so forth that people are going to be able to obtain through their third-party payer. It restricts the type and the level and the frequency of treatment uh, in terms of how it will reimburse, how third-party payers will reimburse, and also tries to limit access to care with, of course, the primary care provider who is the gatekeeper. Um, and so if I want to see a specialist, I first have to go to my primary care physician and get a referral for that. So I can't just go on my own, which for me as a nurse is very frustrating, I have to admit. I did not enjoy this period of healthcare. But of course that's how HMOs like Group Health and Kaiser still operate, is through a managed care sort of approach. They also control the level of reimbursement for services. So if I am a specialist and then have a contract under that managed care umbrella, I can only get so much for services. And quite often, the primary care physician might be rewarded or penalized based on referrals and utilization of testing and so forth. Quite often, capitation goes hand in hand with managed care, particularly if you're looking at a health maintenance organization like Group Health or Kaiser. So that's a form of prepayment where a fixed amount is paid per health plan enrollee for a specific set of services over a period of time. So for example, I'm in the human resources area at Boeing, and I'm going to negotiate the contract with Group Health as a part of the benefits for all the employees at Boeing. So I negotiate a fee per employee at Boeing and with Group Health, and Group Health agrees to pay for all prenatal care, for all well child visits, with no, perhaps no um, fee, copay when people come in, $20 copay or something, and as is in the Affordable Care Act now as a law, all the well visits and annual exams and that sort of thing, which used to not be a given. But because uh, HMOs are very driven by keeping people healthy and providing care within that fixed amount per enrollee, they've always been very good, of course, about doing preventive kinds of services and encouraging people to come in and get their annual exams and so forth. What they also try to do is keep people out of the hospital so that they can manage those funds and reduce their risk. I believe it was in the later 80s when Congress actually required HMO to have a risk pool of money available to keep sort of a savings account in case they went over. They had a lot of sick people and so forth and went over the amount that they had set aside to use to cover services. In general, this works very, very well, particularly if you have a healthy pool of people that you are covering, which is frequently what happens for employers because they have a younger workforce with families as opposed to Medicare, which is an older population. So managed care is actually not a new approach. In 1929, the Ross Luce Clinic was established by two physicians, Donald Ross and Clifford Luce, who felt that care could be cost effective and good quality care. And so they contracted with the County of Los Angeles to provide care to about 2,000 employees. And again, one of the reasons it worked very well for them was that these were young families. And so not real high-risk sorts of patients. They provided cares like prenatal care, well baby visits, immunizations, and some hospital inpatient care and so forth. They actually grew and had established several clinics throughout the county, which later became Cigna, and is still an ongoing concern today. In 1933, Dr. Garfield had just finished his residency at Los Angeles County, and as you might recall, that was during the Depression, and so he was having a real hard time getting a job. So he secured a contract with Industrial Indemnity to care for about 5,000 construction workers who were there working on the Colorado River Aqueduct out in the Mojave Desert. But pretty soon he was in the red. He was in kind of bad financial state, mainly because he was a great guy and he was not turning away anybody. So regardless of their ability to pay. And also, he was really big on adequately equipping the hospital so he could take care of injured workers and stabilize them before they had to make the journey back to Los Angeles. So he made his case to a couple of executives at Industrial Indemnity saying that it was really better for them if they had some kind of a plan for the workers because this was precarious work, high risk work, and injuries would hold up the dam and so forth and or the aqueduct. And so they finally saw that it was to their advantage to prepay part of the premium and also money per worker per month to cover work-related injuries. And then the workers each contributed a little bit too. So that was really the beginning of the kind of third-party insurance that we have today where the employer and the employee contribute to the plan. And so he actually went on to establish Kaiser Permanente. That was the basis for the Kaiser Permanente group, started with Kaiser Construction. And then in the 80s, of course, we saw a real rapid growth of HMOs because people in Congress took notice. They established the HMO Act of 1973, realizing that this was a very cost-effective approach.